Hi, I'm Betsy Nicoletti from Coding Intel. Thanks for joining me today. We're going to talk about interprofessional consult codes. We've had the CPT codes for quite a while, and we got some HCPCS codes in 2025, so I'm updating the video. What are these services? These are consultative services without direct contact with the patient, and it's done through internet, medical record, and telephone consultations. We'll see the full description of those soon. The CPT codes are in the E&M section for use by physicians and non-physician practitioners who have E&M in their scope of practice of any specialty. CMS developed some HCPCS codes in 2025 for services provided by a practitioner whose scope of practice is limited to behavioral health treatments. That's kind of awkward, isn't it? But we'll see the full definition and see how they've defined that. The 2025 HCPCS codes really mirror the format and the description of the existing CPT codes, except for who can provide the service. So starting with the CPT codes, there are 5 codes for use by physicians and other qualified healthcare professionals. CPT says other qualified healthcare professionals. CMS says non-physician practitioners. There are so many abbreviations for these group of professionals. I learn a new one all the time. So there are 5 codes for use by the consulting clinician and 1 code used by the treating clinician who spends time getting information together for the consulting physician. And we're going to hear about that code later. Now, CMS specifically requires consent for these non-face-to-face services, for communications-based technology services, for care management services. CPT doesn't talk about consent, but then they don't say that the doctor has to get consent before they do an appendectomy or remove that lesion from the arm. But CMS says verbal or written consent is required in order to provide this non-face-to-face service. You want to document consent in the medical record. So if it's a written consent, it's in the medical record. If it's a verbal consent, then I suggest that you document who obtained it and when it was obtained. So this is a hindrance to providing these services because the consulting practitioner never sees the patient. The patient doesn't go into the office to be seen because this is a non-face-to-face service, and the patient probably isn't logging in the way we do with not probably, the patient isn't logging in the way we would do with a telehealth service where you get to get consent as the person clicks through in order to get to see the clinician. So we'll talk about this again, but this is a major hindrance to providing these services. So here's the first one, 99446. Interprofessional telephone, internet, electronic, health assessment and management service. An assessment and management service provided by the consultative physician or other qualified healthcare professional, including a verbal and written report to the requesting clinician. And it's 5 to 10 minutes of medical consultative discussion and review. So verbal and written report is required, and it's a time-based service. So anytime we have a time-based service, we've got to make sure time is documented in the medical record, in the clinical note, not in the billing record somewhere. Time needs to be documented. So 5 to 10 minutes, verbal and written. The next 3 codes are 11 to 20 minutes, 21 to 30, and 31 minutes or more. And these carry the same definition that we saw on the prior slide, requiring a verbal and written report. There is a 5th code for this interprofessional assessment and management when only a written report is provided or is performed. And it's 5 minutes of medical consultative discussion and review, but there's no upper limit on that time. So if there isn't a verbal and a written report, if there's only a written report, the only code we have to bill is 99451. While we're here, notice that this 5 minutes has a work RVU of 0.70, because I'm going to come back to that in a minute. So these interprofessional consult codes, these CPT codes, can be used by a physician, nurse practitioner, physician's assistant, clinical nurse specialist, certified nurse midwife. It can be for a new patient to the consultant or an established patient with a new problem or an exacerbation of an existing problem. So new problem or existing problem. But the consultant can't have seen the patient in the past 14 days and can't see the patient in the next 14 days or the next available appointment in order to bill the interprofessional consult codes. So let's say it was a cardiologist and they had seen that patient in the office a week ago. Now they're admitted to the hospital by the hospitalist. They can't perform an interprofessional consult. They can go see the patient, do a face-to-face service with the patient, but they can't perform an interprofessional consult because they saw the patient 7 days ago. Or maybe the neurologist says, listen, I don't really need, I need to see this patient. I either need to see this patient today and I'll come in and see the patient, or have them come into my office in the next 2 or 3 days if they had availability, or the next available appointment. So if the plan is, after discussion with the requesting clinician, that the consulting physician would see the patient in the next 14 days or next available appointment, you can't bill the interprofessional consult codes. And that's written in the section of the CPT book in front of the codes. So just as a reminder, for 99446 to 99449, greater than half the time has to be spent in this medical consultative verbal or internet discussion. Only 99451 may be billed if more than 50% is in data review and analysis, and we're not allowed to report these more than once every 7 days. Document time in the medical record. Provide a verbal and a written report. Can be provided in a facility or non-facility setting. And the written or verbal request for this service should be documented in the medical record. Now, I said I would come back to that 0.7 RVU because this last CPT code, 99452, is for time that the treating clinician, physician or other qualified healthcare professional, spends preparing, getting information ready to send to the consulting physician. But look, here, that 30 minutes is 0.7 work RVUs instead of 5 minutes. So this can be billed by a physician or non-physician practitioner. It's got this single time unit. So we're going to say we can use the midpoint rule. So we can use between 16 and 30 minutes. Doesn't have a range. It may not be reported more than once in a 14-day period, and it has low RVU values. So it seems, in my opinion, to undervalue the work of the treating physician. Okay, how about our HCPCS codes? So we got some new HCPCS codes in 2025, and the last bullet on this slide is an article about all those new HCPCS codes we got in 2025. I think I called them a bonanza at the time because there are about 30 of them. So there you can read about these HCPCS codes on the website. So there are 5 codes for use by a practitioner in a specialty whose covered services are limited by statute to the services for the diagnosis and treatment of mental illness. And then 1 code may be used by the requesting practitioner in a specialty whose covered services are limited by statute to services for the diagnosis and treatment of mental illness. So these codes basically mimic the CPT codes, except that their very definition describes the practitioner's specialty who can perform them. Other than that, the definition is the same. GO546 is for 5 to 10 minutes, including a verbal and written report. And then the other 3 codes are for the 11 to 20 minutes for the additional time when the service takes a longer time. And then when we have only a written report, we have a code GO550. So if there is no verbal report, This is the code that the professional would use. And finally, we have GO 551, and this is for the treating or requesting practitioner. And again, look at the verbiage in the HCPCS description. In a specialty whose covered services are limited by statute to services for the diagnosis and treatment of mental illness. And of course, what that means is they have a license in their state, and the license, it limits them to mental health treatment. They can't go and treat a respiratory illness. And then this code to prepare the information for the consulting clinician is 30 minutes. So there are pitfalls for both of these. Is consent documented? We've got to have consent documented for Medicare, and I would say you want to do it for your other payers as well because you want it to be part of your workflow. Is the request documented? This is usually documented in an inpatient service, in the orders, but make sure in the outpatient service that it's documented as well. Is there documentation of the discussion of the verbal report and the written report? Because most of those codes, the timed codes, require both a verbal and a written report, so you have to have that documented, and then is time documented. So thanks for joining me today to talk about these codes. I appreciate you all being here, and I look forward to seeing you another time. Thanks very much.